Okay, I think we are actually live, right?
Should be.
Okay, so good evening, Chris.
Good evening or good afternoon for me.
Good afternoon for you, yeah. So, good evening to all those who are participating to our monthly webinar. I hope that you can hear me well. So basically, we will go with Chris, our education director, through Digitsole features. We will discuss how to use dynamic movement assessment with key pathologies. Of course, you have a chat actually, so you can ask some questions. Uh, Probably we will try to answer most of the questions by the end of Chris' presentation, if you don't mind. And I wish us a lovely evening.
All
Okay,
right.
it's all yours.
All right. Thank you, Oscar. Okay. I'm going to share my screen here. Do, 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 do. Okay. So, for just to make sure you all understand, so this is a what we call a reoccurring webinar that covers the analysis of the Digitsole Pro walk, run, and performance rehab module. And what we do is we review the analysis, the output. So after someone has already completed the test, then we look at an analysis and we use an analysis with a specific pathology to review the process of how to look at the analysis. So today's analysis is, again, it's going to be focused on walking. So we do this every month, but I'm trying to use a different use case each time. So that way, if you want to come back and return, you'll see hopefully some different information that you might find useful to you. So for this month, I chose a patient to give you a little bit of background. I chose a patient who had a cervical spine injury that resulted in damage to the spinal cord, but this was 13 years ago. And so the patient presents and has a walking pattern with a lot of increased tone, especially on that left side. And the patient has been very active, and the patient wants to be active again, and he just is reaching retirement age, meaning that he can be done working and he can relax for the rest of his life. But he was a very active person. He was in alpine skiing, um, and was a runner and hiking. And unfortunately, he has a lot of difficulty with walking, let alone running. And but in his mind, he pushes it. He still tries to, in some ways, do try to do what he used to, but he's just physically not able to do so. So he's been cared for on a regular basis, more of a maintenance type care, but we wanted to try and see if we could do something different for him that might actually help. So one of the problems with his condition is the lack of control, the lack of mobility, and the increased tone. We suspect that it's having a negative influence on his mobility. And in fact, that because he attempts to walk normally, and which includes the speed, he tends to walk very, very fast, that he's actually at a risk of falling, which also has some other problems. So what we did, we spoke to the patient about attempting a new approach. And the reason was, even though, most of you that if you are familiar with neurological conditions like a spinal cord injury, that there's a window of opportunity to actually make some changes. So we wanted to see if there was still some opportunity, and the opportunity that we were looking to investigate was the use of shockwave therapy, extracorporeal shockwave therapy, using focused shockwave, although we were also using a radio pressure wave or extracorporeal pulsed activation technology. I won't get into that specifically, but the idea was to evaluate the potential difference in treatment that this may have. So let me pull up the first analysis. And so what we did was we took an analysis before treatment, and then we took an analysis after treatment. So when we look at the dashboard here, the things that come up first are symmetry, cadence, and speed. So those are very simple and easy metrics to help identify sort of globally what potentially might be going on with a patient. So the symmetry characteristic, that is based on contact time, right? So the amount of time that the patient spends with their foot in stance phase as they're going through the walking cycle. And so what we see here is it's in the red. And so these colors designate if it is outside of the normative range, if it's inside the normative range, or if it's near the end of the normative range. So we use 3 colors to designate that. If it's red, it means that it's going to be outside of the normative range. And this could either be in a population normative value or a biomarker, right, which is specific to that particular patient's profile. And then so green is going to be within the normal limits, and then orange, yellow is going to be on the end of normal limits. And the reason for that is if I see green, then I can assume, okay, I don't need to spend time there. So this makes it easier to focus on the areas that I want to spend most of my time on. Okay. So when you pull up the analysis, you'll also notice up top here, there's general and details view. So we're going to start with the general view, and then we will get into the details view. So if you're new to this, then you may not know, but you can actually add some information in here even after you've done the analysis. And also to know that this is the application that is online. So this is on the computer, and that's why it looks a little bit different than what we have on our mobile device. I usually do this when I'm showing patients, so it has a little bit more information to it, and then I can also send a copy of this report to the patient, including some of the information that we also put in there. I also like to put in some information regarding their shoes, and then usually in the notes I also write down the pair of shoes that they were using, because that can have some important implications to the data, especially when you're going to compare 2 different sets of data, maybe a pre-test and a post-test. And I will say that I don't normally do a pre and post test in one treatment, right? Because that could be tricky. But this was a specific purpose, because we wanted to show something to the patient and see if there was an acute or a more immediate response to this. So we can see that symmetry, so there's an 80% symmetry value, which means that the comparison between the right and the left in the stance phase is 80% equal, right? So it means that there's 20% that is not equal or asymmetrical. So that means in red, I'm going to want to take a look at that. The cadence, so that is the number of steps per minute, how fast, or the number of steps that they're taking relative to their speed, right? And that's why we also look at the speed. So he is at 2.4 miles per hour, and that's within the normal limits. But like I said, he has you might even call it a dangerous gait because of the way that he walks. It's not equal, and he walks, I think, a little bit too fast for his ability. So let's look down here and look at the walking profile. So there's not a huge, very large difference in between the strides, but there's a 2-inch difference between the strides. So it's enough, at least for me, to take into consideration, because what you're seeing here, even though the strides are very similar, we see that there's a much larger stance phase, so 64.5% versus 59.3%. And so when we're looking at the spatial temporal parameters of a walking profile, the average, is about 60% spent in the stance phase, 40% in the swing phase. So for him to have similar stride lengths, then it means when he has a very long stance phase, it means he has to move through the swing phase more quickly on that leg. And what's interesting is you see that even on his affected side, his abnormal leg, we see that the stride length is actually a little bit longer. So if I see something in here, and again, we've already identified that the contact phase, the symmetry is off, I can click up here and I can click on the advanced, and then it gives me a little bit more information in terms of the spatial temporal profile of the walking. And what we see here is the stride duration between the two is very similar, right? And that makes sense because his stride lengths are very similar. But again, we're seeing some differences between the stance phases and certainly the swing phases, at least in percentage, right? And so relative to his duration, what's interesting is his stride length is actually on the shorter side. So from a pathological profile, what that means is he's taking some normal time in terms of his stride, but it's not the right distance. It's not the right length. He's inhibited a little bit. And again, that's probably because of his condition. So this is based on his demographics as well. And then we look at the swing phase, and we can see that on the left side, he's within the normal. And then it's actually on the right side that says that he's taking a little bit too much time. And let's go back and think about that for a second. And so the swing phase of one leg is going to have a relationship to the stance phase on the other side, right? Because that means that if he's spending more time in swing phase, in stance phase on one foot, it means he may be spending more time in the swing phase on the other if there's an equal stride length. And that's exactly what's going on here. Is he's attempting to compensate for his abnormalities and try and make it as equal as possible. And this is something that we tend to see in people that have chronic conditions, is they work really hard at creating, trying to create equality in their movement patterns, but they're limited, right? Because they don't actually have equality, because again, he has a very detrimental pattern on that left side. And then we look at the stance phase, and this we already knew that he was spending more time in the stance phase on by 80 milliseconds on that left side. So we already knew that. But hopefully that gives you some indication as to why you see some of these differences, and they're going to be somewhat related. Okay, so now we're going to look at the gait line, and this is what is interesting. And this is what then also wants me to go and look at the pronosupination angles, right? So remember that we typically heel strike with a slightly inverted heel for most people. And then it goes into a neutral position. And then when we toe off, the heel starts to either stay neutral or go out into eversion a little bit. So that's fairly normal, even though the foot tries to supinate, and the foot is supposed to supinate in the forefoot, right? Because that means that we transfer our weight. The center of pressure is supposed to transfer over to the first and second toes, right? Your big toe and then your second toe when we get into that propulsive phase. So what's interesting is you see on this left side, we can see all these numbers are in red. So he's spending a lower amount of time on heel strike. So he transitions very quickly from his heel to his foot flat position. And that's where he spends extra time. And then he moves very quickly into that toe off position. Well, why do we see that? So remember, if you were here last month, we talked about the older adult patient. And when you're in foot flat position, that's going to be your most stable position. And so people that have problems don't want to be in an unstable position for an extended period of time. And again, we see that here because he's also slightly lower in that propulsive phase. So what we can do is we can actually click on absolute and it gives you the exact numbers. Okay. And I don't get too worried about exact numbers if they're the same from side to side. But as you can see here, we do have some slight differences between that, especially during that foot flat position, right? And the reason that this is showing 2 less here, even though that 187 is also low, it's relative to the foot flat position and how much time you should be spending. So that's actually how that's calculated as an overall marker relative to the entire stance phase. So I'm just going to go back to the relative here. So what we're looking at here is he heel strikes fairly normal, but then, or at least it looks like he does, and then he actually stays on the lateral aspect of the foot, and he never goes back into supination to transfer his weight, his center of mass, over onto that first and second ray. So he's staying on the outside of the foot, and he is performing his propulsion or toe off on the lateral aspect of the foot. And what we'll see is that's also going to influence some other characteristics of your walking profile. And so, in other words, there's only certain ways that you could actually accomplish that, which means that you're going to have to compensate for that, have a strategy in some of these other areas. So let's look at the propulsion rate. So the propulsion rate is a ratio between the hip flexors and the plantar flexors. And so, as I said, he works really hard to walk as fast as he does, even though he probably shouldn't, just based on his presentation. And we see that he's pretty normal. So he is using his plantar flexors along with his hip flexors. So again, as an example, in the older adult patients, as we age, one of the strategies is, and it's because we're losing some of our core stabilization and strength, is we tend to produce more propulsion from the plantar flexors in late stance phase into early swing phase, right? And we use less hip flexors, and usually that's going to be because of a decrease in that core stabilization. Okay, but we're showing that again. He is pretty active. He tries to be as active as he can, and we're seeing that it's pretty normal between the hip flexors and the plantar flexors, and we're seeing good symmetry between the right and the left side. So let's go up to the top here, and I'm going to click on the details view. So we get a little bit different information here, especially this pronation and supination angles. So we see on heel strike, foot flat, heel off, and toe off, we see that they're off, and it's a fair amount, especially on this left side, but it's probably because it's reduced, on the right side, but it's probably because it's reduced on that left side. So that's a difference. Is there a best? We'll look at the corridor here in a second. So there is some normative value to this. And then as we see here, he remains and actually increases in that heel inverted angle, right? So the calcaneus is pointing towards the midline, but yet his right foot is following the normal trajectory or pattern as we heel strike, and then that transitions into a more foot flat position. And again, we continue the normal pattern on the heel lift on that right side, but he's further increasing that angle, the inverted angle on that left foot. And then we see over here on toe off, That right foot, again, is following a normal pattern, but the left foot, he's going into even more of that heel inversion position. So if we click on the advanced, this is a really nice graph to show my patients or other practitioners to show that trajectory. So the green corridor, right, follows that normal pattern. So this is an interesting presentation. So I can actually put my cursor over the points and it gives me the actual value as well as the standard deviation, right? And that's actually what the min and the max is the standard deviation. So there's a couple things to look at here. One is the actual angulation, and this green corridor, as we call it, is the normal path after, I think we have over 70,000 analyses and millions of steps. So we've been able to develop this normative value for our system. And so that's the normal path, but he is not following the normal path. He's actually continuously going into an abnormal pattern. And if you remember back when we looked at the gait line, it actually shows us that he does not transition over to the first and second toe like he does on that right side. So we look at those actual numbers and the trajectory, and we see that that is definitely going to be off. And I can visualize this too as I'm watching the patient walk. But here's also something to take into consideration. So the standard deviation, there's normally supposed to be a standard deviation, and statistically we call that a covariance, right? It's a percentage of the deviation, and there should be some. And the reason is because that actually allows us to respond to a changing environment, right? So if you stepped on something or you slipped on some ice or something like that, it means that we can respond to it. So there's a buffer zone. You can see that he is so tight. There's no deviation, especially in that foot flat position, right? During the stance phase, and actually throughout most of it. So when I see this, especially neurological patients, that's really common in some of these chronic conditions. In fact, if you evaluate the gait patterns of cerebral palsy Paralympians, right, people that have the condition that have trained really, really hard to get really good, to do that, they have actually reduced their variability, and that was a strategy. It's a compensatory mechanism that we see in those conditions. And then we see it's still tight over here, but at least there is some deviation from the midline, and he's not exact, but he is following that pathway. So of course, having such a dysfunctional limb on the left side definitely is going to affect your right side, right? But at least it's pretty close. So we go a little bit further down. So the foot progression angle, so that gives us two metrics. One, we're going to look at circumduction. How far does that leg swing out from the sagittal plane during that swing phase, right? So when we initiate propulsion, we initiate the swing phase, we should see hip flexion, knee flexion, initially plantar flexion, and then very rapid we transition into dorsiflexion, right? Because our toes need to clear the ground. We also see circumduction. So all of those factors are associated with the foot being able to clear the ground, right? Because we don't want to go too high and we don't want to be too low because we could hit something and potentially trip over that. So people that have potential issues with a knee or a hip or even the ankle, they tend to compensate for that in some of those other joints, as well as increasing circumduction. So I used to do this to my students. We would have the students wear a full knee brace in the completely locked extended position. And if you've ever seen someone walk like that, then we know that they have a very large circumduction. So we see his circumduction, and they're pretty equal from side to side, and they're within those normal limits. The other characteristic that we get is the angle the amount of external rotation, right? That's the rotation around the z-axis. So normal is going to be somewhere between 9 and 15 degrees. And that's normal during the gait pattern. That's also pretty normal. If you were to have someone just stand in a static posture position, they're usually about the same. So it's on average about 10 degrees of external rotation. So what we're seeing here in external rotation is going to be represented as a positive angle. Internal rotation is going to be a negative angle. So an internal rotation is not normal. And so again, this makes sense because we saw, right? I go back to my pronation supination, and it's represented here that he does not go onto the first and second toes like a normal person does, right? And so I'd mentioned this earlier that he has a bit of I called it a dangerous walking pattern because he looks like, it won't take much and he could trip and fall, especially as he is toeing in. He does not have good clearance. And so that's a potential problem. So he compensates for that in various aspects, like the foot progression angle, as you're going through the center of mass. And so his pronosupination angle is also going to be off, right? And he does not have good strength to perform dorsiflexion to clear his foot. So he actually has a little bit more knee flexion. And that actually causes him to have a higher angle here in that toe off because he's trying to compensate for that, especially in comparison to his right foot. He has pretty good clearance, so that was a good thing. And that's one of the things that we look at with regards to fall risk, right? We call that minimum toe clearance, MTC, or foot clearance. And so he actually has pretty good clearance, but it's these other characteristics that minimize the trajectory of that leg, which one, it's going to have an impact on his performance, and two, just because of everything that we see, he's actually at a fall risk as well. So we did this analysis, and I discussed it with the patient briefly, and then we decided to perform some treatment. And so we did radial pressure wave along the paraspinals and his cervical spine. So his cervical spine injury was at approximately C5. And so we did the paraspinals, and then we performed focus shock wave, extracorporeal shock wave at the level of the pathology, so at C5. And then we did spinal mobilization in the cervical, thoracic, and lumbar. So we did not do anything to the lower extremities or the pelvis itself. So we treated the patient, and the patient said, I'm not sure I feel any different. So he has a very guarding sort of attitude about him. And he's actually depressed because of his condition. And that's one of the things that, we're talking about to overcome with him. And so that's why we decided to do a follow-up analysis, especially because, he says he couldn't feel anything. So with your system, you can actually click on those three dots, and it allows you to do a comparison. Like I said, I don't normally do this during the day of a treatment because the acute responses, sometimes they don't necessarily happen. It would sometimes it's like, testing someone's strength, having them do one session of exercise and then expecting it to change. Some of our things do, especially when we influence the pain generators and we reduce nociception. So on follow-up, so this was the pre and this was the post. And so I'm not sure I would call 3% improvement necessarily an improvement, but there was a bit of an improvement. And this was interesting too. And what I mean by interesting is he actually started walking a little bit slower. And as I mentioned earlier, he forces himself to walk fast because of his mentality and wanting to walk fast. And so what we're able to show from this, and it could just be at least his speed shows that he has a little bit better performance when he walks a little bit slower. And in the end, that's actually what part of the conclusion was. And so we see that, remember, he had a 49-inch and a 47 on pre, and then he had a 47 and a 47. And so what we're able to accomplish is some equalization of his stride length. We actually increased his double support phase, which I was kind of happy to see because, again, his walking pattern was a little bit dangerous. Now, his stance phase is very similar, and that makes sense because, he was at 80 and 83%. So that didn't change a whole lot, but we started to see some equality in that, and we can start to work on that. But that wasn't my concern. It was more his walking pattern. And so here's his center of mass. So as I said, that one of the important factors in having a normal gait pattern is being able to transition over to that first and second ray. And so what we started to see was exactly that. So he was able to start transitioning over to that first and second ray. And I think as we continue down, you'll see some other things that change that were, again, pretty important. And so we started to normalize, that transition. Now, as you can imagine, if you know gait, that, for him to do that, it also meant that we're probably going to be changing some other factors. So this stayed the same, and that's key too, right? Because you don't want to make people worse, and so you want to make sure that your metrics are positive. And so propulsion rate stayed the same. Now, when we look at these other metrics here, so we look across the board here, and we remember that he just continuously progressed into that position. Okay, we reduced it from the beginning, and we were normalized between the foot flat position. So that's actually a good start, because remember that foot flat position is also going to be his sort of safety position. But if we go all the way into the toe off position, we see that we went from -23 to -18. So we're still not at 4. We're still not as good as the right foot, but we saw about a 20% difference, again, just within that. And I'll explain why that was pleasing to us. But then we look at the foot progression angle, right? And so we reduced his internal rotation from -6.5 to -2.1. And that's actually, it's either the result or the reason for some of these other changes that we're looking at. But the reason, that we were excited about this was because we actually changed his walking profile. And as a result of that, we decreased his risk associated with a potential fall. And as we explained to the patient, unfortunately, given his condition and his pathology, there are limitations, and that, a 13-year spinal cord injury, and him wanting to be able to go back to alpine skiing and playing tennis again, at least the way that he used to, was probably not feasible. And at his age, we also needed to start to take into consideration some of the other factors associated with lifestyle and quality of life. And that, what we ended up doing was also having an influence on reducing his fall risk profile, which, again, at least showed him that we were capable of making some of those changes. And all right, 1 point, it's 135. So I think we did pretty good. Okay. So let's see if we have any questions. Can the session, is it recorded? It is recorded.
Yeah. I answered this, Chris.
Oh, you did? Okay.
There are some other questions, like from Zach is asking if can you bill Medicare 96000 with this?
Actually, let me see. Here's the first question. Can be with Medicare. So Zach, that is a possibility. What we found is a lot of people are billing 97750. So sometimes that's going to be between you and whoever the provider is in that particular state. But this is an FDA cleared medical device, and the metrics are validated. It is repeatable. So it's if it fits within the realm of how you're actually using it. So for example, when I do gait training, we will do an analysis, and as a result of doing the analysis, and then we make some potential changes, and then we do a follow-up. And so there is some opportunity for functional evaluation, to gait training, to gait retraining, and depending on the condition, because you can't gait train necessarily any pathology, but so we have had some people with success in getting reimbursement for various different types of codes.
Chris, then Zach is asking, can the info in the desktop app be sent to a patient portal in My Athena EMR?
So it generates a PDF file. So like my software, I can upload PDF files into my patient files. So it does work for something like that. Because it is a PDF with graphics, depending on your system and where you are located, there are firewalls for certain systems, like in government programs, and so you'll have to check on that. But you can actually export. So I export it and upload it into my patient software as the full PDF file. So it is quite possible. Yeah, before the end is a recording or informative. My Digitsole won't upload my report after an assessment. Let me think about that for a second. I'm not sure if it's actually generating the report and then. So it sounds like maybe there's an error. And so this is Robin Dono. I'm trying to think where Robin might be. Robin, if you can maybe contact your distributor, or if you want to contact me, let me.
Robin, where are you from? Just a question.
Oh, okay. She's typing. The UK. Okay.
Okay. So, Robin, what I suggest, if you can write me your email, and I will be in touch with you tomorrow. Is it fine to go a little bit more in details?
Yeah. So if Robin, if you just want to contact Oscar, I guess would probably be the best thing to see if we can get that fixed. Thank you, Zach. I'm sure we will be in touch, and as you know, we've been working with them on this process.
I'm also writing my email here.
Okay. And yeah, so one thing I didn't show Zach and the rest of the group for that matter is, so you can do a comparison between two analyses. It also shows you an evolution. So for example, if I've got someone that I've tested multiple times, it has a graphical representation of each one of those assessments in one single view. So it makes it real easy to see the trajectory of the changes as a result of your intervention, or an additional injury, or in this case, such as a surgical procedure. Student pod here. Are these training courses? So Shira, yeah. So we do. So this is one that a lot of people that actually have the system. So that's why I don't get into how to set it up and the background of gate or anything like that. But yes, we often hold, I don't know, Oscar, how many? I think there was a total of like 24 courses last year. So they're on different topics and pathologies and approaches. And so now that you are registered, I think that it'll automatically send you that information when we do hold other events. Does that sound correct, Oscar?
That's exactly the case.
All right. All right. Okay. Any other questions? Shira is typing. All right.
Shira,
Well,
by
listen.
the way, where are you
Go ahead.
from? Just curious to know.
Another one from the United Kingdom.
Okay, great.
Okay. So, hey, listen, thank you for listening to me speak. This is good job security when people show up. And next month, I haven't decided which one I'm going to show, but I think we're going to do another walking one. So it'll definitely be a different example. And I think what's going to happen is as we move forward, I think so that's, let's see, November, December might actually be a running one. And so we will we'll continue to mix it up a little bit. Oh, Zach's got another one. I'm curious, let's say forefoot isn't in supination, then you make an orthotic with a forefoot valgus. Where do you see the change on the that's a very good question. So at least what we found out, it quite possibly will. And part of the reason is where the sensor is located, Zach, although it's not measuring exact supination, it is in fact measuring the trajectory of the foot. So for example, in where the sensor is located right south inferior to the navicular. And so it's almost measuring the foot trajectory as a solid model. And so if they do in fact start going into supination, it should therefore also have an influence. And the reason is, especially once you're in a shoe, it not that a shoe and creates an entire block model of the foot, but we do tend to see that exaggeration in the midfoot to the rear foot. So that is exactly what we're attempting to accomplish with this organization with Solo and so on. All right. So be on the lookout. Again, thank you for listening. Have a great evening or afternoon or morning, depending on where you are. And we look forward to seeing you on the next one.
Yeah, Chris, first of all, thank you very much. And I just want to mention for our distributors and practitioners, we are doing this webinar one in a month. Please make sure that as many as other practitioners will be aware about this webinar, will participate, because this is definitely, as you can see, really very helpful, especially that it's presented by Chris. I wish you all great afternoon, great evening, and we next month. Take care.
All right. Thank you, Oscar.
Thank you,
Bye
Chris.
now.
Bye. Bye.